Good afternoon, everyone. I'm Dr.Anathalakshmi. I'm basically a pakka gynecologist, a clinician. So the speaker, before me was too technical. Though we are building AI in reproductive medicine and gynecology, it was too technical for us. So very glad to be among a lot of clinicians like you. So my topic would be on reproductive medicine, the very tool, digital healthcare we are building for our patients. So I'm very happy to be a part of this conference, AI in Healthcare 2.2 at Yashoda Hospitals. Thanks to all the organizers and Dr. Shivakumar Manikam especially, who invited me for this conference. So precision fertility. What is precision fertility? So at present, we have a lot of tools for reproductive medicine. We have AI-based tools which we, procure from Western models, especially Canada, US, and even Europe. The tools we call Violet, Magenta, SID, which we use in our labs, in our IVF labs. We've been using for a few years now. So what we are actually trying to do is build models based on Indian population. We all know, even the speaker, one but last speaker did say something about how the tools in radiology were not useful in our patients. All the X-ray findings were wrong. So it's similarly like that. You know, our patients are the oocyte aging of our patients, the demography of our patients, the BMI, the diet we have, the culture, everything is different when compared to the Western models. Especially in fertility, we see advanced ovarian aging, advanced spermatozoa aging. We are aging 5 to 6 years faster than our Mediterranean counterparts, than our European counterparts. So what we are trying to do is trying to build models based on our patients. So what is the future of personalized reproductive care? We all know fertility is going down, infertility is on the rise. Every 1 in 6 couples suffer from infertility. So fertility care is moving from standard IVF protocols to data-driven personalized reproductive pathways. AI is helping clinicians improve prediction, precision, and patient-centered decision-making across the fertility journey. So why do we need this? Why? Because each couple who come with infertility are different. We have patients at 25 years coming with azoospermia, with nil sperms. We have patients with, 26, 27-year-old women coming with premature ovarian failure with an AMH of 0.1 with no follicles to induce. And we have couples at 42 years, a 42-year-old woman coming with a good AMH, with good oocytes, but rather she might not have a good quality oocyte, or she might have, we might in turn give her a baby with Down syndrome. So each couple with infertility is different. So it's very important that it is one of the major fields where we have to personalize the therapy for our patients. So what we are aiming to do, better prediction, greater precision, patient-centered care, and better outcomes. Of all fields, we feel that reproductive medicine is a need for all this. So precision fertility uses clinical data, imaging, lab data, and patient history to individualize care. So we do have come across AI models in telemedicine, which integrates all this in reproductive care. We believe in a few years, patients would not have to come visit us for each, for each scan. We have had follicular scans, which the patients can do on themselves recently. There has been a device that has been come up. And we also have protocols, which the chatbots, which the previous speaker said, the chatbot can assess the patient's history and put them on specific, treatment models and give them protocols so that the patients can come to us only on the day of the egg pickup, only on the day of the embryo transfer. So we are trying to build telemedicine models, which are already available. We are trying to specifically build more advanced models on that. So it includes personalized stimulation, better prediction of response, smarter embryo selection, and more tailored counseling. The goal is not just pregnancy, but a safer treatment and lower dropout and better patient experience. Why fertility needs personalization? Infertility is a complex, multifactorial, and emotionally demanding for couples and families. We all know that most of our patients do not conceive even with the first IVF cycle. Some couples need a few cycles, 2 to 3 cycles. Even my own cousin, she conceived in her 5th IVF cycle. but it is very emotionally demanding. Even if it's an IUI treatment or an IVF treatment, for every beta HCG result comes, the patient has to come sit with us. It's very frustrating when the treatment turns out negative, because it's also a financial investment as well, and it's a social stigma, we would say, to not have a baby, to answer people, to answer the in-laws, to answer the relatives, to even go to work. We see a lot of women who leave work and stay at home because they want to concentrate on trying to have a baby. So it is very emotionally devastating for them. So when we try to bring in precision into this field to give them better results, I think we reduce the cost to the patient and to the resources and to the nation as well. So traditional fertility care often applies standard protocols to biologically very different patients. Personalized reproductive care aims to match the right investigation, protocol, and the right patient at the right time. So where AI is changing fertility care? AI is trying to predict ovarian response and help personalize stimulation plans. It improves decision timings and trigger and oocyte pickup, which are major, which play a major role in deciding the maturity of the eggs and hence the number of blasts we develop and the clinical pregnancy rates as well. It supports sperm and oocyte and embryo assessment in the IVF laboratory and standardizes quality control, which is very, very essential when it comes to IVF lab automation, even in the presence of AI, and reducing variation in embryology workflows. We even have recently control trials which compare, very conventional labs and AI automated labs. We are only able to give similar results. Even with an AI automated lab, which is able to give a 6 times faster precision when compared to a senior embryologist, the clinical pregnancy rates have not improved. So what are we doing? We're only incurring more cost to the patient, more cost to the center, which is more of private in India, and also to our resources. So that is what we are trying to do. We are trying to standardize the quality control across all centers. So the shift from protocol-based to patient-based care. Why do we need a patient-based protocol in reproductive medicine? Because like I told you, each patient is different. Each woman is different. Every one of their hormones is different. We are not doing textbook-based protocols anymore. I think this stands true across all specialties, especially in reproductive medicine, because each dose of gonadotropin is going to be very expensive, and it is not going to be the same for 2 patients of the same age, same BMI, and the same follicular count. The way the woman responds is different in the first IVF cycle and the second IVF cycle. So why do we do this? So that's what the machine learning will help us, so that we try to standardize these protocols across the various data available to us, so that in the future, it will help clinicians like us to have a precise protocol for the patient and a better clinical outcome for the patient as well. So the earlier models were mainly like protocol for many patients with minor adjustments. We'll have package. We'll have, this package will have recombinant gonadotropin, and the other package will have human HMG injections. So we are not doing that anymore. We see how they respond and what this particular patient needs. So that is the need of the hour. So the newer model, what we are trying to build, has to assess the ovarian reserve of the patient, which can be calculated with the antral follicular count and ultrasound, and the serum AMH of the woman, the age, the prior response, however she has responded to her previous IVF cycles, to the previous IUI stimulations, or even an ovulation induction cycle. We see patients, with single dose of clomiphene, with single dose of letrozole coming with multiple follicles, or patients, not responding to any, stimulant in 3-4 cycles. So all these have to be taken into consideration by these models. The follicular pattern. The pattern of the follicles in the ultrasound, whether there's increased stroma, the patient might respond less. If it's multifollicular, she might have a hyper response. And the lab behavior and the risk profile of the patient. So the treatment guided by ovarian reserve, age, prior response, follicular pattern, lab behavior, and risk profile. So AI helps detect patterns too complex for routine human interpretation alone. This is how fertility care becomes predictive, preventive, and more precise. So AI in embryo and lab decision making. AI-based systems have shown predictive accuracy of about 73 to 75% in identifying embryos most likely to implant. AI can reduce the subjectivity in embryo grading and support more consistent decisions across labs. So it may eventually reduce the need for invasive steps in selected cases. So when we integrate, a few of our centers, even in Delhi, have integrated AI with the time-lapse imaging, with the embryoscope. So we believe that when we do this, we are able to predict which embryo has the better implantation rate. So this helps reduce invasive testing like PGTA, which incurs more cost to the patient. Almost we spend 20,000 per embryo for a biopsy. So this can be reduced with the help when we help this machine learning study models and help in better prediction of the implantation of these embryos. This is especially relevant for high quality, scalable IVF care. So better outcomes, safer care. AI supported customized protocols have been associated with up to 30% lower risk of ovarian hyperstimulation in reported applications. Ovarian hyperstimulation is something that is out of context. We all run OHSS free clinics now. We taper the dose so that OHSS doesn't happen because it's very mortal. It is very sad that a woman has to go through that, have an ICU admission, of face fatality just for the want of having a baby. So the rate of OHSS, we have brought it down to less than 0.01% with the current antagonist protocols. So AI will even help reduce the incidence of OHSS even in donor cycles, which is more common in them because they are fertile women. And AI can help clinics move from reactive correction to earlier risk anticipation. So this anticipation, this prediction is what we are relying on with AI, because even with the best protocol we use, we wait for 5 days to see the scan and see the response. So with AI, when we have better prediction, the precision should be more. The promise is not only higher success, but fewer complications, fewer failed cycles, and more efficient use of resources. This is one thing we are stressing on. Even in our AI summit, we did talk about ethical frameworks in this. Because when it comes to rural women, they walk across cities, they come across cities to access IVF care because it's not very much available to them. So when they have to spend so much and reach out, they are not in a very much affordable state to go for a few cycles. When you cannot promise results in a single cycle for a 45-year-old woman. So when you're able to increase the precision of your treatment, when you're able to say, yes, this embryo can implant and give her a clinical pregnancy rate, yes, you're going to reduce the cost to the patient and improve the resources as well. So why this matters for hospitals and health systems? Precision fertility improves not only clinical outcomes, but also workflow efficiency and standardization. This is what we're talking about. Even for a chain which has 50 to 100 centers across India, each center has a different clinician who decides differently for their patient. So if you're able to automate, you're able to give a standard workflow and optimize that, this is what's going to help the clinicians predict and give a better treatment outcome for the patient. It's going to be very useful for both the clinician, the management system, the workflow, and the patient as well. So AI can automate repetitive tasks, reduce administrative burden, and help teams focus on higher value clinical decisions. For management, this means better quality control, scalability, auditability, and potentially better patient trust. For policymakers, this opens the door to broader access and more equitable reproductive care delivery. So equity and equality are two things which are very, very important in reproductive care, which we must stress also in other specialties as well. So the Indian opportunity. So the Indian opportunity, why our market is very high, is that we have a lot of population, our infertility is on the rise, and we have huge data with us which remains unused, unexplored. So India is the ideal environment to build affordable, high-volume precision fertility systems. If developed responsibly, India can lead in ethical, scalable, and patient-centered reproductive innovation. So precision fertility must remain human, ethical, and equitable. So ethicality is very, very important when we try to integrate AI in any clinical network. So if we build it well, the next era of fertility care will be more precise for our patients, more efficient for our hospitals, and more effective for our doctors as well. Thank you.
So, okay, this topic I think we understood better since yesterday and today morning, because it was more into our language. So only one question for you is, what is the difference in the cost when you use AI protocol and with precision and your normal routine fertility treatment in IVF?
Yes, currently, we do not have any Indian models that integrate AI. We are using models from Canada. There are two models for oocyte prediction. We call it Violet and Magenta, and one for sperm assessment called SID. So the cost to the hospital is procuring the software from them. So, the first two models which we use would be how they bill it is either they sell the software, or the other model, they charge it per patient.
Yeah.
So it will directly, the cost will incur on the patient.
So how much is the difference?
It will be huge to the hospital and the patient as well. Not everybody, can afford. Even in India, even patients who can afford would not want to choose for it. You know how our patients are. So that is why we are stressing on building our own models, which would be better efficient to treat. Because Western models are not helping us at all. Like I told you, even though we integrate AI in our workflows, in our labs, they are no better than our senior embryologist, though it gives us 6 times more faster and more precise result. So what is the point in just increasing the cost to the patient to give a faster result, which is comparable to our own clinical pregnancy rate? So when we are able to study these models, help machine learning do this for our patients and our data, I think we'll have more precision in this. We'll be able to treat, even as clinicians, we would see patients from one locality will be different, the other locality would be different. We see patients from one particular village responding to a gonadotropin differently. We see patients from metropolitan cities responding differently. So we have to, include demography while we develop AI for these patients, so that we are, the machine can tell us, the model can tell us that this is what's going to work for this set of patients. Even if this patient is getting treated at a clinician somewhere in Delhi, the model should be able to predict. So that is, we are actually building. We all should come together, build that for our patients.
Okay, thank you.
It's the follicular scan is what we are doing now manually, ma'am. The patient comes for a vaginal scan, and we monitor it in the 5th day, 8th day, and even on the day of trigger. Now there is a handheld ultrasound machine that has been developed, something like a probe, which the patient can use it at home. So it's not very freely available, but the machine has been developed. It's simply like a vaginal probe with the handheld, one is enough, ma'am. That's reusable, ma'am. They can use it with a cover, yeah. No, ma'am, it's like the normal ultrasound. It's a different probe, that's all. It's repeatable.
Thank you, doctor. The models which you are saying, have you built it, or you are proposing somebody to build it?
I'm actually working on it. So we are working on AI in reproductive medicine and digital healthcare, women's healthcare, yeah.
Okay, so where did you collected this data from? You said the models which you are using exist, taken from Canada. Now you want to build the models. How you collected the data? Can you give some?
The data is still at the proposition level. We are at prototype.
When the data is at proposition level, what models you built, ma'am?
The model is based on what we are acquiring from there. Ours is in prototype level. So we are yet to, partner with various organizations to collect the data.
Okay, because it is whenever first of all, let me tell you who I am. I'm a machine learning guy, okay? I build models. I build models based on data. So if the correct data is there, only then I can build the model. I'm thinking where did you got the data, so that how can you build the model?
We are incubated with GIMS. We are also associated with IIT Madras and IIT Delhi. We are trying to, partner with various organizations across India to get the data and build the models. We have not yet done with it yet, yeah.
Okay. And still, like, if you are building, okay, with any generally available data, and I'm looking at your presentation, how can you made it personalized? Since last at least 10 years I am working on personalized medicine, I could not able to do that with so much of genomic data
Oh, no,
access
no.
to me.
It's very much personalizable, so that's what you're
That
working
is
on.
what, how? And I just want to.
I have not yet patented my idea, so I'm not telling that here.
Okay, thank you.